Okay, thank you very much. Good evening, everyone, and welcome to this meeting of the London Borough of Newham's Health and Adult Social Care Scrutiny Commission. Can everyone present virtually hear me? Fantastic. This evening's meeting is being held in Town Hall in East Ham. Members unable to attend in person at this location are able to join remotely. However, they'll not be able to vote and their attendance will not be officially recorded, though their virtual attendance will be noted in the minutes. I'd also like to welcome any members of the public and press who are watching on YouTube. With regards to meeting etiquette, participants in the meeting, please can I ask that you indicate you wish to speak by raising your physical hand or by using the hand up symbol on the Zoom dashboard. On this point, may I remind those attending as partners or witnesses to introduce themselves when speaking for the first time with name, role and organisation for the benefit of the recording and those watching the meeting, and to keep microphones muted when not speaking. This meeting of the London Borough of Newham's Health and Adult Social on 17th September 2025 is now called to order. So good evening, everyone, and welcome to tonight's first meeting in the current municipal year. The last few months have been a time of many changes for the Directorate we scrutinise. Before we move into the agenda, I'd like to take a moment to pay tribute to Councillor Neil Wilson, well known to members of this commission as Newham Council's Cabinet Lead for Health and Adult Social. Neil's funeral took place on the 11th of September, and it was in recognition of this that the Commission rescheduled its meeting this evening. As someone who had himself served on this commission for many years, as a Cabinet Lead, Councillor Wilson always made sure he was available for our meetings, set in regular catch-ups with his team, and ensured that when the CQC recently came calling, the scrutiny opinion was included in their deep dive. Our thoughts are with his family and friends at this time. I feel we should just pause for a minute's silence to honour his passing.
Hand up. Hand up. We'll usually step. If they.
Okay, thank you, colleagues. We now move on to the business of the meeting. Item 1 on the agenda is welcome and introductions. The changes continue. Before I introduce my committee, I'd like to extend a warm welcome to Councillor Rita Charder. The passing of Councillor Wilson, Councillor Charder is the newly appointed Cabinet Lead for Health and Adult Social Care, and I'm delighted to report yet another graduate of this committee. We'll be hearing a lot from you over the next 2 hours and indeed the whole municipal year. But would you like to say anything publicly about your background in the area?
Thank you, Councillor Masters. Can I just also pay tribute to Councillor Wilson? Even in the 2 weeks that I've been here, I've actually found myself a couple of times thinking, what would he have done in this situation? So I hope I can live up to his fantastic work. In terms of my personal background, as you know, I am an ex-graduate of this alumni of this great committee, and I have served on ELFT as the council's representative. What a lot of people may not know about me, because we don't often get the opportunity to converse as colleagues, is that my background is actually in the voluntary sector and working specifically with organisations that are in crisis, that are often working with people that are in crisis. There you go, John.
Oh, sure.
And so from that point of view, I've often worked at the intersection of public health and adult social care. And currently I'm working with a befriending organisation in a neighbouring borough as well. I don't think I'll ever be able to do as much justice to this as Councillor Wilson did, but I will certainly give it my best shot, and I hope we can keep up the productive relationship between Scrutiny and Cabinet as you've had so fruitfully over previous years.
Thank you, Councillor Chadha. The change in Cabinet lead is just one of many affecting tonight's London Borough of Newham team, and our committee acknowledges the unique disruption this has caused to the production of papers for this meeting. I'd also like to welcome Alan Adams as the borough's new interim Director of Adult Social Care, and note the departure last week of the borough's long-serving Director of Public Health, Jason Strelitz. Jason's leadership challenge the pandemic will be remembered, and we wish him well in his future endeavours. Tonight, I understand that Claire Greshek and Adiola Agbebiyi will be jointly leading representations from Newham's public health team. Moving on to my commission, I'll get the committee to introduce itself, starting with myself. I'm Councillor Susan Masters. I represent East Ham South, and I'll also be chairing tonight.
Councillor Joel Aguda for Plaistow North Ward.
Hello, Councillor Jane Lofthouse, representing Plaistow South.
Councillor Bachika Wana, representing Canning Town South.
I'm Anne Easter, one of the councillors for Royal Albert Ward, and a former nurse.
John Gray, West Ham Ward, member of this committee.
Okay, moving to the back of the room.
Hello, I'm Councillor Cameron Corbett, Councillor for Maryland.
I'm Councillor Mohammed Ghani, representing Rolling Ward.
Councillor Shapam Hamid, representing Canning Town North Ward.
I'm Noor Begum, Councillor in Little Ilford Ward.
And I'd also like to welcome Councillor Odoy, who I can see online, who's not feeling terribly well tonight, but has taken the trouble to join the committee. And although you're not going to be allowed to vote, sadly, we really appreciate the effort you've sort of taken to join us. I'd also like to introduce this Commission's Senior Scrutiny Officer, Erin Sangian, who is tonight with our Scrutiny Manager, Artemis Cassie, and Scrutiny Officer, Kevin Odongo. And I'd also like to welcome any other council officers, members or partners who've taken the trouble to join us this evening, who we will introduce as the meeting progresses. Item 2, membership. This concerns membership, apology for absence and notices of substitution. Under this item, are there any apologies for absence received from members of the Commission?
Councillor Keeling.
And we've already noted that Councillor Odoa is appearing online.
Chair, may I also share Councillor Mumtaz Khan apologies as well, please?
Thank you. Apologies for absence from members will be noted. Item 3, declarations of interest. Are there any declarations of interest from members of this committee for any item on the agenda? Councillor Easter.
Thank you. I am just about, I think, still chair of Newham Health Watch before it assumes a whole new being or does something, whatever is decided. So I will be particularly interested in areas that Health Watch cover.
And Councillor Aguda.
I don't know whether I should declare it, but I used to work with Alan Adams. So it's lovely to see you.
Oh, that's nice.
So next item I've got is item 4, minutes. This is to agree the minutes of our meeting held on April 2025. Does anyone have any amendments? Councillor Gray.
Just for accuracy, and being picky, and in the spirit of Councillor Wilson being a well-known grammar fanatic, there's a slight typo, declaration of interest. Councillor Gray declared that they hold a better leisure membership card than he holds. And the spirit, I'm sure Neil will be very proud of me bringing this important matter up.
Noted.
Want to be misgendered.
Doesn't want to be misgendered.
Exactly.
Subject to that one tweak, Can I move that the minutes of the Health and Adult Social Care Committee meeting held on the 29th of April be agreed? Correct. Do I have a seconder in that?
Seconded.
Councillor Lofthouse. Thank you. It's noted that the minutes are agreed.
Agreed.
Item 5, committee's work plan. The Commission's work plan for 2025 to 26 is attached in our papers. Members will recall that a work programming session was held on the 19th of June with the adults and conversations from our partners. From that, a range of topics were identified. The draft plan is included in the meeting's pack, which has been shared in advance with partners and accepted by our umbrella Overview and Scrutiny Commission as the areas we wish to take scrutiny in 2025-26, on the understanding that evolving circumstances might require changes. Are there any comments or suggestions on the work plan that members would like to raise at this stage? Fantastic. Okay, so in that case, I move that the Health and Adult Social Care Scrutiny Work Plan for 2025 to 26 be agreed. Do I have a seconder?
Yes,
Councillor Easter, I think, is there. So on to the management of the business of the meeting. As chair and with the Commission, I intend to take the agenda as read. I plan to allot around 30 minutes to our update on emerging matters, and then 40 minutes apiece to our two substantive items. The first phase of our close to home scrutiny strand, looking at hospital pressures and how partners across our health and care system are working to keep care closer to home. And our second item on alcohol harm and its attendant inequalities. Next item is update on emerging matters that I just referred to. So the purpose of this part of the agenda is to offer an open space for members to raise questions around the impact of national developments upon services in our borough, or to receive updates on ongoing and emerging issues and strategies within our Newham health and care system. I'd like to welcome for this section Councillor Rita Charger again as Cabinet Member for Health and Adult Social Care, Alan Adams as Interim Corporate Director for Adults and Public Health, Charlotte Pomeroy is joining us as Chief Participation and Place Officer, who is covering for our Integrated Care Board Place Lead, Joe Fraser-Wise. I see we've got Anna Björkstrand from East London Foundation Trust on the Zoom. Is there anybody, and also Dr. A.D. Cooper and Alex Chidgey from our Adult Social Care team. Is there anyone else on the moment? Because I'm not picking anyone else up. Oh, Claire Drescher from Public Health. And we've got, do we have Bailey Mitchell or? Yes, fantastic. Okay. And Michael Jones, do we have?
Chair, and Simon Reid, our Director of Commissioning.
Fantastic. Who's calling in remotely from somewhere exotic in Europe, I'm guessing. And Michael Jones, fantastic. Thank you for that. And then in terms of Health Watch, I'm expecting us to have been joined by Vasili Singh. Have I pronounced your name right?
Yes, it's Vaishali.
Vaishali. Excellent. Thank you. I'll make a note that I get that right in future. And Nicole,
Thank you.
Have we got Nicole Bello as well?
Nicole will be joining shortly.
Okay, fantastic. When we last met in April, we had a discussion about our preparation for a CQC inspection. Since then, the inspection of adult social care services has taken place and we're now awaiting the outcomes. So I will invite an update to the committee on what can be shared at this stage from Councillor Charder.
I'm afraid at this stage, definitely until this afternoon, unless anything's changed, we have not heard anything back on that. That's not unusual from what we understand. There are several boroughs that were due to have feedback last week and they still haven't heard. So at this stage, no news is good news.
And I know we've got Dr. A.D. Cooper on the Zoom. Dr. Cooper, are there any updates that you'd like to share with the Commission in terms of the Practice Improvement Board?
Only to say that the meeting, because of the inspection, was cancelled, and we're meeting in a couple of weeks' time. So there's nothing current to share. That at subsequent meetings, I'm sure colleagues will be able to update anything that's required.
Okay, are there any questions from the committee before we move on to the next topic regarding CQC inspection? My understanding is that we were originally anticipating the draft report in October, but we're now thinking that might actually be landing sooner than that. Okay.
Yeah, it was actually due. We are told it is arriving this week, the draft report, and then there'll be a time to look at it and comment back. In the meantime, the findings are confidential, and I think October is more like the formal date. But as Councillor Charter said, the programme has slipped in some boroughs, so there's no guarantee.
Okay, thank you. Second item I have refers to the services that were terminated at Chargeable Lane for some of our residents and their replacement within alternative services. We have covered this item in some depth. So I'm just wondering whether, again, there are any other updates or whether we can now accept that all of the 37 residents affected now happily settled in their alternative opportunities. Do you have anyone to talk to that item?
We bring in Simon Reid on that. Just I'm not 100% certain if we have got any further updates, but it'd be useful just to.
Okay,
Simon.
Hi all, Lydia Drummond's on the call.
Yeah. Hi everybody, it's Lydia Drummond, the Assistant Director of Commissioning in Adult Social Care. So the older people service that was supporting 37 residents closed on the 11th of August. Out of those 37 residents, 2 opted out of formal services following their successful engagement in other community-based activities in the libraries and other places. One person has chosen a tailored solution, which includes a reduced package, attending Subco Trust 1 day a week, and the other day that attending a community-based activity. Sadly, 1 resident passed away during the transition process. 12 residents have transferred to the in-house dementia service, as during that period they were diagnosed with dementia or have a brain condition that manifests like dementia. And then significant work was done with the 21 other people who were upset about the decision. And a resident committee was formed and work was done with them so that they were able to remain together, and they were transferred over to Subco Trust, who made significant changes in how they support people and who they support, as in currently, prior to this, they only supported those from the South Asian community in order to accommodate those residents. And there was a settling in period. It's now been about 6 weeks. And so those reviews to make sure that there's no teething issues, etc., are due to take place towards the end of this month.
Okay, if you can just sort of report back and keep the committee informed on whether they have all been happily resettled, I think that would be very reassuring.
No problem.
Thank you for your contribution there.
Thank you.
Are there any questions from members on that item? Okay, the other action outstanding from our April meeting was the impact of the Supreme Court ruling on gender definitions and local services. At the time of our last meeting, it was felt it was too early to know whether there was any impact. I'm just wondering whether anything's changed since then. I'm assuming not, but.
So I should introduce myself. Tom Ellis, Director of Strategy for Newham Hospital, and actually Simon Ashton's apologies for today. No is the simple answer. We're still awaiting guidance. And I actually spoke to the Divisional Director for Medicine today and the Divisional Director for Women's and Children's, and both of them have not seen a single patient come through that they have changed how we've treated them in response to the gender ruling. So at the moment, it's I think we wait the guidance from nationally and see what it says, but so far no impact on the services we provide.
Fantastic, thank you. The other item I really wanted to touch on that's changed is the new 10-year plan. At our last meeting, we noted the government's national announcements on the NHS, including the abolition of NHS England, of its functions returning to the Department of Health and Social Care. And at that stage, the awaited publication of a new NHS 10-year plan. As part of these changes, members heard that integrated care boards would be required to reduce their running costs by 50% by the end of the year. Although detailed guidance and information was still awaited, we noted that this would have significant implications for borough level services and agreed we would continue to monitor the impact. We now have the full NHS 10-year plan, which was published in July. So I'm interested in knowing what each section of our local system welcomes within it and where you see the challenges, just as a really quick 360-degree revolution through our system. So Councillor Charder, could you lead off just in terms of LBN, maybe bringing officers in?
Absolutely. Thank you. So I think one thing that we need to be clear about, those of us who've been around for long enough will have seen iterations of this plan in one way or another. And there's nothing revolutionary new in this plan. And I think we have to acknowledge that. What it does do is push us into a direction of closer working together, which I think was already on the cards in many cases. What it doesn't do is be clear about the money that's available to make this happen. And that's the real mission. I think in terms of kind of making sure where LBN is on this, we need to take every full advantage of this. There is more that we could do about possibly working with our neighbouring boroughs, about kind of trying to maximise prevention as well in this space as well. So I think we'll continue watching this. The neighbourhood kind of element and the localism element in this is something that I think sits quite neatly with what is going on elsewhere in terms of placemaking in the local authority, and we've got to be in the right place at the right time to take full advantage of that.
Okay, would any of your officers like to add to this very briefly?
Yeah, and without repeating anything that Councillor Childers said, the three approaches, three shifts that are being sought from sickness to prevention, from analog to digital, and from hospital to community, they're all approaches that any good local authority has been working on and would welcome. So I think the issue for Newham is what's our starting point and how do we link in with that? And if you like, Chair, both Alex and Simon, we could invite them to comment on that in terms of briefly in terms of what's happening at Newham at the moment. Of course, resources is a challenge. The other one is excellent partnerships is what's going to make the most of this. Really good personal relationships between system leaders and a willingness to work together, understand each other's issues and look creatively at what can be done. So hopefully that will be what happens in Newham. That's the challenge.
I seem to remember some comments about social workers possibly being skilled up to deliver health tasks, which might be possibly a conversation that we need to have going forward.
So the interesting thing is that it's an integration in its various forms has been around for decades, and some places have always done better than others. So this is, as Councillor Charter said, the latest iteration. That's not to dismiss it. It's really important, and there's some very, very important stuff in it. What makes it work, the different types of integration, is system leaders working well together, and then that going down through the organisations.
Okay, I think we've heard quite a lot in terms of certainly the social care side. So Claire, if there's anything that you want to add from a public health point of view, really quickly, that would be appreciated, and then I'll move on to other partners.
Great, thanks very much. Yeah, absolutely. So very briefly, the shift to prevention is obviously a very welcome thing from the public health side of things, and it has been mentioned, you know, it will help to solidify and reinforce the work that we've already been doing in Newham together with the 50-step strategy. There's a real opportunity with the changes coming in the NHS for us as a public health community to really support that with the skills and resources we have in local government in public health. And yeah, I think so just basically a good opportunity to bring prevention to the forefront and be thinking about that across everything that we're delivering.
Charlotte, it's really interesting that you're here this evening and we don't have Jo Fraser-Wise, who would normally be here speaking on behalf of Newham's position within the Integrated Care Board. At our last meeting, the blueprint for what services might look like now, you've had more of your central operating costs cut, wasn't available. Can you tell us a little bit more about what the Integrated Care Board structures will look like, certainly at a place level, which is where this committee is focused, and you know, also in terms of how it's going to affect the centre and your strategies? Are there services that, projects that Newham might have been looking forward to that are now no longer able to happen because of these cuts?
Thank you very much, Chair. I mean, I think it's important to set this in the context of the wider 10-year health plan and the whole new operating model for the NHS. So not only are there changes to ICBs, integrated care boards, they were sort of announced first with the regional and with the ICB blueprint, but now, as you mentioned, the abolition of NHSE and its merger with Department of Health and Social Care, the creation of new regional offices, which will be on the same footprint, so there'll be a London region, and the model region blueprint has just been published. So really important that the changes to the ICB aren't seen in isolation. The clear direction of travel for integrated care boards is to become strategic commissioners of the healthcare services in their local area. There's definitely an emphasis on commissioning rather than delivery, and that does affect our future operating model. And in terms of our future operating model, we've got a focus of services and resources on strategic commissioning. We consider we're doing that once for North East London, but with our feet firmly in place in terms of community engagement, really understanding local population needs, recognising the diversity of our communities, the level of variation we need across our patch, but equally recognising that local people want a level of consistency. They want to see that they are getting similar services, achieving similar health and wellbeing outcomes across North East London. So it will change our approach. So our new operating model, as I say, focuses on strategic commissioning, which we see as strategy, population need, analytics and insight and intelligence, a commissioning function, much of that will be once for North East London, and then a finance and resources function. And interestingly, reflecting back to the 10-year health plan, I know there was a mention of there are no new resources, but there were significant resources in the budget for health services. And what the health plan sets out are some of the additional levers, the changes to contracting mechanisms, the changes to the way that money flows through the NHS, which gives some additional weight to our ability to actually affect the three shifts that Claire mentioned, the emphasis and focus on prevention, which is really welcome, but making sure that the resources can follow that. In terms of place, our approach has been to say we will have a reduced place delivery teams, and over time we see those functions being hosted by the local neighbourhood health provider. That is as set out in the model ICB blueprint. We're having conversations in each place at the moment as to how some of that hosting of functions at place might happen. We see the small team focused on delivery of neighbourhood services, engagement with local populations, on primary care support, so support to our local general practice and wider primary care functions, and also work around medicines optimisation. So, but in line with the model ICB blueprint, which very much focuses the ICB future on commissioning rather than on delivery, those functions will be hosted by a health provider or local authority provider in the future. In terms of the wider health plan, we welcome a lot of what's in there. It is quite high level. There's a lot of detail to be worked through. There's not a detailed delivery plan, but certainly the 3 shifts we see as fundamental to resetting our relationship, the real focus on transparency and quality of care, on working with local communities, and then for us that really important strand of working in neighbourhoods, which colleagues around at both the virtual room and the physical room have done a huge amount of work to develop neighbourhood models in Newham, with some really brilliant outcomes. So yeah, I'll leave it there, Chair, but happy to take any questions.
Okay, I mean, I have to say, from my point of view, what I've heard is a lot of words, but no actual detail about the specific questions I asked. I'm just wondering whether it'd be possible for the Commission to be furnished with an organogram showing how the structure of the ICB in our local team specifically will change in the light of the new funding that you say is coming down, but equally the central operating costs that have gone, and just actual sort of specific detail of what will still be happening, what will now be happening that might not have been happening before. Just specifics, because I had a lot of very general statements there, but I don't feel I'm much the wiser beyond the fact there'll be a smaller team. And I think it will be really important to capture how Newham's voice will be represented. And along those lines, I would imagine, Councillor Easter, do you want to ask a question around the future of Health Watch, which sadly has been discontinued as part of the plan? So yeah, there's a bit of a gap around resident experience, but I'll let Councillor Easter ask that question.
Thank you, Chair. For many years now, this committee has, I believe, benefited from input from Health Watch, which is an organisation, a voluntary sector organisation that listens to people's experiences and hears what it's like to be in receipt of services or care or whatever it is, or trying to get various services too. And with the apparent abolition of Health Watch, which obviously is particularly sad for all of us, I fear that that voice might be missing, and I wonder how the ICB might think of somehow replacing that, or at least finding a space for that voice. Thank you.
Charlotte, have you started work on that?
Yeah. I'd like to come back to your previous challenge, though, back as it were. We're not able. We've got, obviously we'll be going through a significant restructure. To take out 50% of our running costs means taking out 50% of our workforce. We're not able to launch that consultation until we get the go ahead from National, and therefore we're not able to share organograms or structure charts, because obviously we want to share that with our staff and workforce directly affected.
I understand that. I mean, I'm not setting a time on that, Charlotte. But if you can,
of course, in time,
once all that's been done, bring that back to the committee, just so it's clear to us what this is going to look like.
I was just explaining why I couldn't give that now to the committee. I'm not holding anything back. It's just that we obviously, I mean, I am holding something back, but for good reason, because we want to share it with staff. Until we get the go ahead from National, we're not able to.
I totally understand.
So I just wanted to be clear on that. In terms of Health Watch, we were as shocked and surprised as anybody by the recommendations in Penny Dash's review of the patient safety landscape, where we believe there is a loss in the independent voice of Health Watch. So it's not just the engagement function, the ability to talk to local residents, it's that independent voice, that right of entry and visit to. There has been no detail shared with us as the ICB, apart from what was in the review wording. I had a meeting with our 8 Health Watch leads this afternoon, and likewise they have had no further information given to them about next steps. And I'm not sure local authority colleagues as commissioners of Health Watch have had any further information since the review finding. But I think it is beholden on us all to make sure that we are both reflecting all those functions of Healthwatch, that independent voice, that ability to engage with local communities, and that ability to really participate in co-design and commissioning of services. So we're really keen that we find some solutions jointly with local authorities and with partners on that key finding. But as I say, there's been no further communication with us as the ICB in that space. I can see Simon's got his hand up.
Thanks, Charlotte. I can see Simon's got his hand up, but I'm just very aware that there are some other really key partners outside of the local authority that I want to bring in, and that we're quite tight on time, which probably comes down to me being over ambitious in terms of trying to squeeze this item into the first section. So if I can move on to to Michael or Bailey in terms of the East London Foundation Trust. Do you have any thoughts you'd like to share?
I'm happy to jump in. So I think, a lot of what's already been expressed from Charlotte and others relates to mental health as well. I suppose the 10-year plan is pretty general and high level, and I think that with the 3 shifts in particular, there are lots of aspects of it that mental health services have already engaged with, I think, pretty well. In particular, the sort of shift from hospital to community crisis care in the community and home treatment teams have been a sort of long-running success story there, I think. But certainly on the digital front, we struggle probably along with a lot of other aspects of the health service in terms of consistent IT strategies and funding. I think the sort of neighborhood model and neighborhood approach aligns quite a bit with our ambitions to work in a more integrated way with council colleagues anyway, and some of the neighborhood work that has been done with partners, I think, helps to prepare us for what comes next. I think there are some specific areas of challenge for us, particularly the sort of assertive outreach function and how we keep track of and respond to those effectively who are high risk to themselves or others potentially, and very difficult to engage with. That sort of Valdo Kellicane examples given, and that is certainly an area of challenge and concern for us that we will continue to work through. And I guess just to make a little plug for mental health, I think we're lucky to have the mental health investment standard preserved, I suppose in name, but I think as a sector have seen some real terms impact on funding in mental health services broadly, not just in Newham. So I think that is something to keep an eye on in terms of mental health's share of the NHS budget. It is at risk, and that's something that we will obviously be thinking about in terms of the expectations of delivery of the 10-year plan in the Newham context.
So I've got a question which probably goes to yourself, but also to Tom. Obviously, we now have the new NHS Trust League tables, which seem to have been rushed through very quickly indeed. What are your feelings about these? Because from my point of view as a service user and a councillor, I don't see these are going to tell our residents what they want to know. I can see that they might want to know about Newham Hospital and how it's faring. They might want to know how a service they're using is faring. But the Barts Health Trust has no meaning to them, I wouldn't have thought. And the East London Foundation Trust, similarly, while you do excellent work with your Council of Governors, I would imagine, again, people want to know about the services that they use. They don't want to particularly look at a trust league table. But Tom, as you haven't spoken so far, I'm going to ask you to come in on this one.
So, I mean, Barts Health came 79th out of 100 and I think 34, 143. But obviously that's 4 different hospitals, of which we are one. So I think the problem is you can't look at those our position and go, that's Newham, because we don't actually know where Newham, we don't have a breakdown of Newham's position within that. And I think that, you know, even the hospital at 134th will have good services within it. And I think the risk is that people look at the headline figure and don't know what goes into those metrics, don't necessarily understand how the figures have been arrived at or how the grading's been arrived at. And what experience or an observation I would make is that people tend to just look at it and go, is my hospital okay? We're number one, we're good. We're number 134, we're bad. And it's a very binary thing that people make a judgment on. And so, I mean, it's too early to say what the long-term outcome will be of the league tables, but various governments have done various sort of league table systems. I think there was the star ratings back in the late 90s and things like that. So we've gone through various iterations of rating without, I would say, a sort of discernible impact in terms of patient flows, activity. It's a prompt for organisations to look hard at themselves. But again, the problem that we have, and quite a lot of hospitals will have this, because quite a lot of hospitals sit within a group structure like Bart's, is you can't pull out your own local hospital from that position.
Bailey, I'm assuming you'd agree with most of that. Is there anything else you want to add before I move on?
Yeah, definitely. Just a couple of points being that obviously this is the first iteration and it will refresh every 3 months. The other thing is that the data's got quite a wide confidence interval, as in we're not really sure how accurate the information is going to be over time until it's run a few times. And then really the last point is league tables are only as good as the metrics that they focus on. And I'm not sure the metrics that are focused on for the NOF is necessarily what members of our community would think of when trying to understand whether it's a good place to receive care or a bad place to receive care. The metrics on their own won't really give you a good sense of that, in my opinion.
Okay. Do we have Jack Edge on the Zoom in terms of primary care? Don't think we've got any primary care representation. Okay, we'll leave primary care to another day, possibly a couple of meetings time when we're sort of looking at that in terms of closer to home. The other big thing that has happened is the independent national investigation into maternity services. And Councillor Laguda, I think you had a question about this.
Yes, we are worried about the inclusion of Barking, Dagenham and Redbridge into the trust, whether that will have an impact on the way we offer services, because Barts has not been scrutinized. So they are quite, we are worried that all these other boroughs will now come into our borough to come to Barts. And that will be a bit more difficult for our patients to actually have the services they need, because there'll be so much pressure having some of these people from other boroughs.
So it will, if that comes to pass. I asked our clinical director for Women's and Children's Services today whether we'd seen any impact yet or would anticipate any impact. And her simple response was, it's too early to tell about this. There is a great deal of coordination between hospitals around maternity. There are good networks around maternity. We will obviously need to understand what the impact is going to be. But at the moment, it's slightly watchful waiting from us to see if and what the impact will be on the hospital. And like all hospitals, we have a finite capacity. So if that becomes an issue, then the hospital will have to think about how it responds to that. But I can't give you anything more definite at this stage to it. We are aware of those.
Okay. Does anyone else from the Commission have any questions on any of the items that we've touched? Councillor Bagoom.
I have one question about my surgeries. We refer on patient for neurosurgery. in Central Hospital. And they have given, this patient is having great difficulty to even breathe out. Very worse, no passing urine at all. But they're given the 8 months waiting to set an appointment. Now, while we are living, question is that where the patient can go.
So is your question about whether there are specific barriers within the neurosurgeon service and
Certain services, even they have been written to all over the UK, who can give the earliest appointment, because he's a very young boy. All of a sudden,
how you,
he is 21 years old.
okay.
So they're looking into it, wherever neurosurgeon is there.
I mean, as a scrutiny, we can't really look at individual cases, but is this a general challenge at the moment to access specialist neuro?
Question that this is the hospital condition. There is no neurosurgeon available. Only 2 surgeons is there in the UK.
Is this a general problem that's being seen?
So neurosurgery within Barts Health is provided at the Royal London. It's not come across my radar that there is particular issues there.
Another one is the different part of the England. So he covers every patient in this area, outside area. That's why this is 8 month waiting.
So I think it's important to know, I suppose, around neurosurgery units is that they are tertiary units that will take out of area referrals because of the high level of expertise they have. I'm not aware of there being particular issues at the London in terms of waiting times vis-a-vis other acute neurosurgical units, but if you want to send me some information, I'm happy to inquire on your behalf.
And I know Charlotte's also sort of shaking her head in terms of the wider North East London system. Would it make more sense for Councillor Begum's inquiry to sort of come over to you in terms of the wider North East London system?
Yeah, I'll liaise with Tom on a response to the councillor's question and that broader point you're making about access to neurosurgery more generally. Thanks.
Fantastic. Okay, I'll make sure that happens. Thank you very much, Councillor Begum. So I'd like to sort of move on from this issue because I'm aware that because there was quite a lot to sort of deal with there, we've run over slightly. But I'd like the key points to be noted. I think that there's going to be a lot that we'll be monitoring going forward in terms of items within the 10-year plan and how that sort of moves forward in terms of delivery. But with the Commission's approval, I'd like to move us on to the first of this evening's substantive items, which is our part 1 of our close to home piece of work. And tonight we're sort of looking at system pressures and responsibility primarily on acute care. We know that a hospital stay can be expensive, but also damaging to the long-term health of our residents, and also that the acute services hospitals offer can be impeded by residents attending A&E when they could be receiving care elsewhere, or patients sort of not being able to sort of obtain settings that might be more appropriate to them through challenges around housing or healthcare out of hospital. The purpose of this strand in our work plan is to understand how health and care partners are working to keep residents' care close to home in a way that makes experiences more pleasant, both for those who do need to access hospital care, but equally for those who don't. So across 3 sessions this year, we'll be examining how the system's different partners are working together to minimise the number, impact and length of hospital stays experienced by our Newham residents in a way that improves their health and wellbeing. Part 1 this evening is about establishing the current landscape regarding acute care. It focuses on data supplied by the hospital primarily and by the East London Foundation Trust, covering activity and pressures, including A&E attendances, emergency admissions and delayed discharges. It also seeks to ensure that the shape of any community services that wrap round is understood To be more specific, we've never, to my knowledge, scrutinised community health services. So I'm glad that Anna Bjorkstrand from Elft has been able to join us in terms of answering any questions for the paper that has been tabled to the Commission regarding the services that they provide. In terms of later meetings, part 2 in November, we'll be looking in more detail at reablement, step down and discharge support, how well the system helps people recover at home and avoid readmission. And then part 3 will examine prevention and the problem of isolation of residents not receiving statutory adult social care, focusing on outreach, neighbourhood support and maintaining independence. The evidence gathered tonight will prove the foundation for those future sessions and for the committee's wider scrutiny of how our system enables care closer to home. For this discussion, submissions have been provided by Newham Hospital and the North East London Integrated Care Board, the East London NHS Trust and from Healthwatch in Newham. The Commission also sought input from the Council's Adult Social Care Directorate on their statutory duties in relation to admission prevention and discharge care. A paper has been shared, but as it only landed today, I think it's probably unfair to expect my committee members to have absorbed its content. So I will defer its consideration till November when we'll be considering the wider delivery of such services. Members will have read the papers for this item, but I will allow some very brief opening remarks. So to begin, I'll invite Charlotte Pomeroy, representing the NHS North East London Integrated Care Board, to make some opening remarks together with Tom Ellis from Newham Hospital. So Charlotte, if you want to kick off on the Zoom.
Yeah, thank you. Thank you very much. So just some very brief opening remarks, because I think the discussion will be the important thing. As we were discussing in terms of the 10-year health plan, care closer to home is very much a sort of facet of that 10-year health plan. Really important to us in Newham, partly to relieve pressure on Newham Hospital, not only on unplanned care, but planned care too, making sure that residents can access care closer to where they live. So that real focus on neighbourhood working, which we've made quite a lot of progress on to date, and recognising that we want hospital to be a place where people go when they're really sick, and so we can use the specialised services they offer to best effect. There is, as well as the impact on individual residents, there is a financial impact, as you mentioned in your introductory comments. It's expensive to keep people in a hospital setting when they don't need to be, and as well as the social and health benefits of people wherever possible staying at home in their community. So this is very much an important strategic direction for us. We're seeing mounting pressure. We've got winter on its way. It feels like winter every day. At times, people are saying in the NHS in terms of demand on emergency departments, but we're really keen that we do sort of effect this shift and that it is sustainable, so that it's not something that in 5 years' time people are saying, yes, we've done that before and it didn't quite work. So how do we really embed this approach? So I'm very happy to take part in the discussion. Thanks. Over to you, Tom.
Okay. Very quickly, because I'm conscious of time. So we get around 3,000 attendances week at the hospital. 90% of our admissions as a hospital come through our emergency department. Only 10% will be elective surgical. And the admissions, which is actually on the graph, table 3, figure 3, shows a significantly sort of greater variation compared to the attendance. Are below the peak of 2023-24. I know the graphs are quite difficult to follow, but trust me, it is. And that in part is some of the work that we've been doing around, we've got more acute consultants working at the front door. We've got a new same-day emergency care system that is treating people rather than in the hospital, but not admitting them, so turning them around on the day. And we've got 2 more ED consultants on the team. And actually, we've also got significant increases in staffing. So substantive staffing for nursing at Newham is now at 90%, which is a big change for us and obviously enables us to give higher quality and continuity of care because teams know each other. Suppose I just want to draw a couple of other points out. So the hospital was built, or the ED was built for between 250 and 300 attendances a day. A normal day at Newham is 450. We've had a number of days in last winter, at the back end of last winter, where we were having 500 plus. We did have a day where we had 560 patients attending in a day. So obviously our ED is not, as it's currently constructed, is not big enough to deal with the flow. So there's a challenge both in terms of infrastructure, but also within staffing and also clinical models, and that plays into the neighbourhood piece as well. Worth noting that we have at any one time out of a bed stock of circa, for the figure I'm going to give you, is a bed stock around 230 acute beds. We have 20 to 30 medically optimised patients in the hospital every day. Medically optimised is the NHS's rather clunky terminology for basically saying they're fit for discharge. But because of care packages or enablement issues or homeless patients, there is delays getting them out. So we have 20 to 30 people waiting in ED. So we have 20 to 30 people waiting to get out. Generally have at any one time 10 to 30 patients waiting in ED for a bed. So there is a circularity there that trying hard through various ways of working, changing ways of working to ameliorate the demand, but it's a problem. We were a hospital built for a population. So the hospital was opened in 83, significantly smaller population, and with the population growth that's coming both for Newham, but also point out Barking and Dagenham, which is on the west side of the patch, and many of whom will look to Newham as their local hospital. There is an absolute demand to look at how we deal in the longer term with these flows. Neighbourhood is part of it. I would note one of the interesting things in the 10-year plan is it actually talks about less money going into acutes. Now, I understand the rationale, but Newham as a hospital is a hospital dealing with a massive population growth. So there is a significant challenge there for us. There's a question about how much it costs. So a hospital stay costs circa £395 a day. 22-23 calculation around direct cost of delayed discharges was 1.89 billion for the NHS. So that's an awful lot of lost capacity and poor patient experience as well. We're holding patients in hospital when they don't need to be there, which leads to issues like deconditioning. I'm just conscious of time.
Yeah, that's a pretty good summing up.
Yeah.
We were talking about patient experience, and something very specifically I know our residents are concerned about is corridor care. Within A&E day-to-day, on average, how many patients have we got experiencing corridor care, and what does that actually sort of look like in terms of the way?
So there isn't an average day. So, and it will flow and flux depending on what's happening across the hospital, demand in ED at any one moment. We are in heaven and earth as a hospital in terms of processes to try and ensure that we have no corridor care, and we have a set of actions going on. I can't give you all the details on them because I know all the details of all of them. But we have had 3 days in a row where we've had no corridor care. And that's the first time in a number of months where we've not had patients in the corridor. How sustainable that is going into winter, a significant challenge, but we know it's poor experience for patients, it's poor experience for staff. They're obviously occupying space in ED, which is small anyway. If any of you have been to our ED, it can get quite claustrophobic when there's a lot of people in there. So it represents a significant challenge to us in terms of corridor care, and we are working really hard to stop it. As I said, we've had 3 days in a row of having none, which is a good start, but I wouldn't want to read too much into it at this stage.
I mean, it seems quite depressing that that's the way we're looking at it. There's been 3 days out of many where we've had none, which implies generally we have more than that. How do we protect vulnerable people who are waiting? Because my understanding is waiting times at the moment are very long. That's not something in the report, so I'm quite interested in knowing what the average wait time is. But if you're somebody who's elderly, and my own father is 90 and he spent several days in A&E, not in Newham, I hasten to add, in a different part of London. And I'm just interested in knowing, in Newham's A&E, when you've got people who are very, very frail, elderly, mental health conditions, or disabilities, how do we protect those people when they've got a wait of that kind of length? If they have a wait of that kind of length in Newham.
So we do have patients who wait for a very long time. If I had to give you a generalised view, the longest waiting patients quite often are mental health patients. So they're in our ED waiting for beds within mental health trusts to come up. And I was on call for the hospital over the weekend, and we had a patient who tipped over 100 hours in ED waiting for a mental health bed. So they're there and we protect them, and it's the right place because it's a safe place for them. It can get very difficult for ED staff, ED flow, for having them in there. In terms of your question about how do you protect vulnerable people, ultimately that's a clinical decision. The clinicians on the floor will be making decisions all the time about relative risk around patients and the need to get patients off ED and into beds and appropriate beds for them. But I can't sit here and give you guarantees that because someone is frail, they move as fast as we would like. That's not always the case. It comes back to the point that if we've got 20 to 30 patients in beds that we would like to, don't need to be there, that's the flex in the system that we're trying to release as well.
Okay. Moving on to the survey that Healthwatch shared with us. Councillor Laguda, you had a question about this.
Yeah, the opinion seems to be negative. Just wondering why is the number of those commenting on hospitals so much lower than other parts of the health system? What are you hearing? Because when you look at the survey, there's a lot of negativity about the hospital services.
Do we still have Vishali online?
Yes, Chair.
Excellent. Do you want to answer to the data?
Of course, in relation to the data that we've received for Newham University Hospital, as the statistics suggest that 62 people commented and there's a 32% positive satisfaction around the services. However, 67% of people commented that the waiting times is particularly too long and is one of the leading negative topic. And feedback also suggests that patients would also like greater levels of communication, more empathy, and more involvement and support in their care plans.
But why you haven't answered Councillor Laguda's question though around why the numbers of people responding are so low. Tom's just explained to us that they have for an A&E for capacity of 250, they're sometimes getting 500 people through their door. So I'm surprised that given the poor response, more of that hasn't been captured.
So how we capture data is qualitative and quantitative. So the current data which is presented is gathered through community insight system, which is overseen by local voice in the community. And these are the comments that are obtained from a variety of sources, including the comments that were posted online, including their care opinions and social media. However, we did ask that if we could include qualitative data that we've received through our entrant view visits at the hospital. That's a separate report.
Okay, I'd like to move on to the data that we've been provided with around admissions. And Jane, some questions
Thank you, yeah.
about this around planned and unplanned.
I wanted to look at the issue, it's a sort of two-part question really, related to planned admissions and unplanned admissions. And perhaps I could prefix it. For your figures just now of 90% unplanned,
Unplanned.
10% planned,
Yes.
and the planned admissions have been increasing and are not now. So I wonder if you could expand on that, and perhaps the second part of the question really, why are there so many unplanned? Are these people who've got serious issues that haven't been identified in time, so they become emergencies? Possible to expand on that?
If I take your first point first, so the planned care piece, a lot of our planned work goes through the Gateway Centre, which is a freestanding surgical centre on the site.
Yeah.
Other name is the orthopaedic centre. So a lot of hips and knee replacements for obviously Newham, but also the London, Whipps Cross, etc. So the beauty of surgical centres is they're not actually physically attached to the main hospital. So the beds in there are in essence ring fenced for elective surgery, for planned surgery.
Yes.
So even if you have a lot of people coming through A&E as we do, they can't actually go into those beds because it's in a building that's about 400 or 500 yards away from the main hospital. So that's why we're managing incrementally to increase the number of planned procedures we're doing, even whilst the emergency demand is increasing as well, because we are getting incrementally more efficient and productive in terms of how many cases we can get through the Barts Health Orthopaedic Centre on any one operating list. I hope that answers your first question.
Yes.
Good. Your second question, there's 1,000,001 reasons why people will end up in ED. Some of it is about access to primary care and other services. And since time began, if you can't access anything else, ED is always open. We're open 24/7 and we're closed. So people will come here to us. I think some of it is that people there'll be issues around deprivation, issues around housing that we know of. All of these drive attendances. There's also some certain cultural issues. So some groups, if you look at East Europeans, they don't traditionally have in their home countries, they don't have a primary care type setup. Quite often in some East European countries, if you're ill, your first port of call is the emergency department. So there's a variety of factors that go into it. But the numbers come through are also just a function of we have a population in Newham that is significantly increasing all the time. And you drive or anywhere in Newham or go on the train, there's a tower block going up, and they are people who ultimately will end up coming to the hospital if they get ill.
So is there an element of communication, education, making people aware when they could go to a doctor earlier or get some earlier attention?
I don't know if someone else is better placed to answer that than I.
Before.
Probably is.
Yeah.
I think one of the things we're trying to do, and it's things like the same day emergency care service, is rather than see them and admit them, we see them, treat them, turn them around and send them out.
Yeah.
Vertically. So but it's an ongoing challenge. We're always trying to find ways to speed flow through the hospital and treat more patients and discharge them rather than actually admit them.
Early.
It's one of the ways that we will deal with the ongoing growth in demand on the hospital.
So one of the things we're going to get onto later when we're talking about alcohol misuse is there's a stat from Barts Health talking about alcohol abuse explains 12 to 15% of admissions. Do you collect data generally on the reasons why people have attended A&E? Because it'd be really interesting to see a kind of anonymised breakdown of that. We do have that data.
So happy to share that. Obviously, you can cut it down to the nth degree. So we'd probably group it into certain themes that people come into. For example, the single biggest area that people will come to Newham ED for is for respiratory issues. But we can break down the information and provide that.
That'd be really helpful. One of the really important tables in the paperwork is where people are coming in from in terms of the primary care networks. Now, starting off with Newham primary care networks, there are some primary care networks where you're seeing 3 times as many people attending as others. Is that because those primary care networks are actually bigger in terms of the number of patients they're involved? So as a proportion, it's a similar proportion? Or are you suggesting that there are some primary care networks who might be maybe shirking on their responsibilities and encouraging people to go to hospital or go to attend A&E rather than coming in?
I wouldn't say anyone is shirking on their responsibilities. I mean, there is more than enough work for every aspect of the health service to be dealing with. I mean, it's a shame Jack's not here because he might have a view on this.
I mean, we'll pick it up for him.
So the PCNs are differing in size. I can't think off the top of my head how big each one is, but they are differing in size. But I would argue that the difference in size doesn't account for the difference in referral rates.
Okay, so that's something we'll take out with Jack Edge then. And then in terms of where they're coming from, there are people who are coming in from other PCNs that aren't Newham PCNs and quite a lot of people from Brent. What's that about? There seems to be over 1,000 people attending A&E from Brent.
I had not spotted that, and I can't give you
That was
answer.
interesting. And then numbers of people who their origin isn't known or they're unregistered. So I don't know whether this goes back to what you were saying about people from some communities just not having a GP. And then when it's other unknown PCNs, what's that about? Because if they're with a primary care network, then surely we know which borough that's in, even if it's not one of ours.
I mean, I can take those questions back to our business intelligence unit to get some more breakdown on.
Yeah, that would. I found that
the main thing I think has to be a glitch. That doesn't look right to me.
Okay, Jane, you've got a question about the remote access coordination hub.
Oh yes, I did. Basically, how is it working? I think that's mainly my question on that. How much success is there through that?
Reach.
And the reach and take up.
So I don't have any figures to give you. I can find out and supply those for you. It's part of the arsenal that we have, but obviously the point about reach is it's designed to stop patients coming to ED in the first place. So it's coordinated by Barts Health.
Yes.
It's interesting. You raise an interesting question. I mean, when you're working in a hospital, you get bombarded with data. I'm not sure I've ever seen any data that shows how many patients would have come to Newham if it hadn't been for reach. So it's an interesting question you ask. Data, but I'm not aware of it.
I'd like to move on to the East London Foundation Trust. In terms of acute mental health beds, the numbers being admitted are lower. And I'm just wondering what's driving that. Is this anything to do with right care, right person possibly? And fewer inappropriate people coming into the system?
Thanks, Chair. I'll have a go at answering that. So we think it's probably a mix of the investment that's gone into community and crisis mental health services over the years, including investment in alternatives to admission like crisis houses. We also think it's probably as a result of our length of stay increasing, which will reduce the availability of beds for people to be admitted to. And just kind of link the Tom's point about NUH, we'll regularly have a number of people on our wards that we think are clinically ready for discharge or medically optimized, with the driver of that being housing. But it's also fair to say that Newham's not alone in this, that across England and London, there's been an increase of length of stay of health inpatients. And we're working very positively with the council, in particular adult social care and housing, to try and improve that flow through our inpatient unit, because again, linking the point that Tom said about waiters, if we're not able to discharge people in a timely way, that means people can be stuck waiting in A&E for an admission, which I think we all accept is not a kind of safe and dignified place for people to be waiting. So I think it'll be a mixed kind of reason as to why our admissions over that 8-year period have reduced.
And Councillor Laguda, you had a question about mental health discharge delays. Question 11, I think.
Question 11, yes. You listed the 5 largest causes of discharge delays: lack of appropriate housing, lack of necessary health support, and lack of care support. You say her housing accounts to 59.5% of delays. How do these factors compare? I don't know whether I've said it properly. My voice is not very good today.
I think what Councillor Laguda is talking about is we've got a list of 5 reasons, and we know that housing is the big part of that, but just sort of understanding in terms of the other factors listed, just how closely they come to that figure, if there's one that's sort of bigger than the others, to get a fuller picture.
Yeah, so I don't have that information to hand in terms of whether one is more prevalent than the other and how we compare to other boroughs, which I think was part of the question, but I can certainly get back to the committee on that. I think, yeah, that we certainly have a lot of challenges with housing. And when we look at people who we discharge to our step down beds, so a kind of intermediary care service for people that are no longer needed on the ward, but don't have a place to go to longer term, the main reason for that is housing. And it's interesting that it's not necessarily a kind of supported housing like social care. So often, although there are delays in the supported living and social care pathway, a lot of it is around emergency accommodation and general needs housing, and there can often be delays in finding who the appropriate housing authority is for an individual, because it might not necessarily be Newham Council. So that process of determining who the appropriate housing authority is, getting that authority to accept a duty, and then sourcing that accommodation can take some time. And then there's the added kind of complication which can sometimes come into it, where if someone doesn't have recourse to public funds and kind of immigration status, can sometimes slow down that process as well. What I would say is we've invested quite a bit in the partnership with housing, with the dedicated housing officer that's employed and hosted within the council's housing team that works exclusively for mental health services in Newham. And we find that very helpful in helping the ward teams navigate those housing pathways, which we're obviously not as expert on as a housing officer would be, and to help speed up those delays when they do occur. But yeah, it is a big challenge. It's particularly challenging in Newham, but I know this is replicated across other areas, but happy to come back to the committee with some more detail on that.
Fantastic. And I think we've got a question from Councillor Ottaway online.
Hello, I just wanted to ask, do you find any sort of trend of the delay in discharge being caused by the ratio of staff to patients? And also, do you find any pattern in residents coming in because of a mental health issue, but then the delay in discharge is due to like a physical health issue or something else?
I can try.
Yeah, do you want to go?
Do you want me to respond to that, Michael? So sorry that So I guess the first part of your question around sort of a connection between delays and staffing ratios. So we have not seen any correlation or link there. In fact, 12 to 24 months ago, we had a safer staffing review, which looked at our staffing in inpatient wards and led to an increase in core staffing across the unit. And we've never really seen a sort of connection between inpatient staffing levels and length of stay. It's often more the complexity of need, which I suppose links to your second question around physical health. We are seeing a higher proportion of our inpatient cohort who have comorbid physical health complexities. Diabetes being a really common one, but also a range of musculoskeletal concerns, bariatric patients as well who have needs that require special equipment. We're having to rely on profiling beds much more, which allows people to get in and out of bed safely. So that is absolutely a factor we're seeing in our clinically ready for discharges.
So
Fantastic.
just to supplement, sorry, can I ask a supplementary?
Yeah, sure, through the chair.
So just those particular illnesses that you said, like the musculoskeletal ones, is there a link then between like mental health issues and those particular physical health issues? And is there anything that we can start to look at in terms of that link?
I guess we're not necessarily seeing a causal link, but I guess I mentioned diabetes in particular because there are often physical health illnesses, long-term conditions, which are more complex and difficult to manage when you have a serious mental illness on top of it. Particularly where those conditions require an individual to self-manage. So we have had to think about how we support people to be both physically well and mentally well so that they can then be discharged safely and manage their physical illness or their long-term condition in the community more effectively. And we have had to work more creatively around that. Interestingly, we do have a joint post that works across bots as well, a diabetes psychiatrist who can sort of help us deal with that complexity in terms of the interface between diabetes and SMI as well, serious mental illness.
Fantastic. I'm very aware that time's moving on. I'm also very aware that we've got Anna Bjorkstrand online who did table a paper around the community nursing services and other sort of community support services. I know we're going to sort of be digging deeper into those in the meeting in November when we get on to what happens when patients are discharged and questions over beds in the community. Did any members of the commission, sorry, John, you had a question, didn't you?
Yeah, no, thank you. I'm just really interested in your reference to the mental health practitioner who's like embedded in the counter services, which personally I wasn't aware of it, and working in social housing myself, and also a great deal of our casework is sometimes not only trying to get people with mental health conditions put into more appropriate accommodation, but sometimes the impact, the unintentional impact of their behaviour on neighbours is a real problem, which I'm sure everybody here is aware. I'll just be interested in finding out some more about this, or just maybe by email through the Scrutiny part. Also, do they assist with the council's community safety officers, or is it just housing? And also, do you engage with other social housing providers, such as housing associations? It seems really good practice.
Very much. Is there anything that can be said briefly now, or would it be better to take a paper outside of the meeting? I'm very happy with either.
Chair, it's my third day in Newham. So, however,
take the paper out.
It may well be that Alex or Simon could may.
Yes, Simon's got his hand up. Would you like to briefly detail the arrangements we have?
Yeah, I think maybe in the next session when we start talking about community beds, it's a really good opportunity to talk about the work we've done with Look Ahead as a housing association to create step-down beds. So like intermediate care can be seen in several different ways, and we are trying to increasingly focus on cohorts of need rather than just seeing someone as like a one-size-fits-all approach. In terms of the housing officer, we've used funding through the Better Care Fund to kind of establish a post in mental health, but also one in the hospital to help ensure that people who are owed a duty are identified early and kind of fast tracked through the system. But as you all know, Newham's a complex place with like various different complex social factors. It's not that everybody is owed a duty, and that's part of the challenge. One bit of evidence that I think for the next session, Scrutiny would also benefit from is some kind of external benchmarking in terms of how Newham performs alongside other boroughs, and that's available. On that, you see that actually from a hospital point of view, we have the lowest delayed discharges in the country. So these are issues everybody's facing, but there's something about the strength of the partnership in Newham that is trying to address these in a joined up way as possible.
Okay, we will be sort of going into all of this a lot more in the November meeting. Before I move on, though, are there any questions based on the information that was tabled by the East London Foundation Trust around the community services that are available, or are we happy to leave that till November when we can sort of look at that sort of in the round and how well that's sort of working with our social care services?
It's a big one.
Okay. In that case, I need to apologise to you, Anna, because you've been online for quite a while, and as it is, we haven't really touched on your area. But I can promise you that when you come back in November, we'll keep you very busy indeed. So thank you for attending.
Yeah, sorry, Chair.
Yes.
I just want to say that I think the point that the councillor made about housing is so important. It's often neglected in these discussions, and it absolutely is an example of good.
We are going to touch on this in November, just to be very, very clear. At the moment, today we're literally just looking at the pressures on the hospital, and then we hope to look at the shape of the services around them. We haven't quite done that justice, unfortunately, because of the time, but we will be doing a very deep dive into that in November. I think there are two resolutions that I feel come out of this. Firstly, I kind of feel that there's space to do some more community organisations around some of these communities who maybe aren't as aware of our primary care services and community services as they might be. And secondly, I've been feeling for a long while that there's something we should be doing as a campaigning council round asking for more beds. And I think as this piece of work goes on, there might be a slight question about where these beds are, whether we need to be campaigning to have an expansion of A&E, or whether it's about having more beds at a community level. And hopefully we'll come to a clearer conclusion of that as the work on this committee goes on. Are there any other recommendations, though, that the committee feel have come out of this sort of conversation? Councillor Corbyn.
Yeah, I just want to agree about the housing issue, because clearly those people that are creating a bottleneck, like taking up beds when they're ready, one of the major reasons they're not going back out is because either there's no housing or it needs adapting.
We fully understand that, but we're going to be dealing with that in a later meeting. Today, it's like we're literally sort of looking at the pressures on the hospital, whether we need to sort of look at expanding sort of beds and education in the community.
There's huge pressure that there's people just sitting there who could be discharged, but there's some...
Absolutely, and we're going to be dealing with that in meeting number 2 in November.
Sure.
So noting those points, I'd like to move that the Commission notes the submissions and comments made during this item and confirms its intention to examine reablement, step down and discharge support in its November meeting before concluding for focus on the preventative roles of public health and other organisations in delivering that in January. So I'd really like to thank all who gave up their time to attend this item, Although you're welcome to stay, you're now free to leave the meeting unless you're sort of participating in our next item. Our second final substantive item of this evening's meeting, alcohol harm, inequalities and response. I'm pleased to welcome a range of colleagues contributing to the discussion. We have Fiona Hackland, Assistant Director of Commissioning Adults and Health. Edward King, I'm hoping we've got online now in terms of being Assistant Director of Licensing and Regulation. Aidan Bowen Avery, Health Improvement Coordinator at the Barts NHS Trust. Mike Ward, Senior Consultant at Alcohol Change UK. Lauren Mulligan from Change Grow Live, otherwise known as Newham Rise, who deliver our alcohol support services. Sarah Curry, a Substance Misuse Commissioner with our borough, and hopefully James Howarth as Police Sergeant, working in partnerships and licensing safe neighbourhoods and under North East Command. Are all those people online?
If I could say a few words, Councillor Masters, I think everyone that you listed is online.
Fantastic, thank you.
And very briefly, to introduce the item, I think we also have Daniel there as well. I can see. Hi, Daniel. Yeah, really welcome this item. I'm going to shortly hand over to Fiona to start us off on it, but really welcome the opportunity to talk about the alcohol-related harms that our residents experience, and the item is going to focus on a range of levels of drinking, but really importantly, a potential inequality that we face in Newham with the link between alcohol and deprivation, and some elements of potential unmet need we have in the borough as well. And obviously, a lot of the presentation will be focusing on opportunities for prevention within all the really good work that we've got going on. So that's all I wanted to say by way of introduction, and I'll hand over to Fiona to start us off.
Okay, I was actually going to ask your lead member, Councillor Chada, whether she had any comments.
In the interest of time, Councillor.
Okay, Fiona.
So I think we sent you through rather a lot of information because you asked us for a lot of information. I'm not intending to do death by PowerPoint unless you really want me to, particularly at this point in the evening. I think one of the things that we were really keen to get over as part of this is to think about the impacts of alcohol across everything and not just focus on people who are dependent on alcohol. I think we need to know that it is a cause, even at quite low levels of drinking, of cancers, that it has, back to some of the discussions that we just had, quite a complex relationship with mental health, including interactions with kind of medications. And it has an impact on the brain in terms of, kind of cognitive function and other things as well. I think we also need to think about the fact that alcohol has an impact not just on kind of mental health, but also impacts on the wider community. I sat in a meeting with the Safety Partnership earlier on today, and one of the things that we were talking about was antisocial behaviour related to drinking, which isn't just the people sitting on a bench in the street corner drinking super strength lager, but just people drinking outside pubs, etc. once they close and they're carrying on drinking outside. So there are costs that are often kind of equated with that, and those are in for both England and kind of estimates for Newham in there. I think that we also have to talk about equity, particularly within Newham, with all the things that we know about in terms of the levels of deprivation that our residents experience. And there is something called the alcohol harm paradox, where in areas of higher deprivation, people experience higher levels of harm from alcohol, even when they're drinking the same amounts of people in wealthier and less deprived areas. There are also disproportionate effects on people that are becoming very known in terms of some of our global majority communities. For example, there's a lot of research that's saying that particularly Sikh men experience ill health as a result of their drinking far quicker than other populations at the same age and at the same levels of drinking. So there are some real equity issues around this as well for our residents. I didn't really want to say a huge amount because I really wanted, well, we've got quite a few experts here from our services, licensed, and from BARTS again, which will link into some of the questions you've had earlier about people turning up to A&E and what the response is there. So I guess unless there's questions potentially about what we presented.
I just to outline to members, I intend to divide this item into 3 distinct parts, just so we do many people who I really appreciate. I know you've done a lot of work with our officers in terms of sort of putting together tonight's panel to ensure that they all speak. I want to start off looking at strategy, data and inequalities before we move on to enforcement in terms of licensing and policing. And then finally, treatment and prevention services in the borough. So in terms of the intro, you referenced some evidence of issues within Sikh communities, and your papers established that certain ethnicities, women and people living in poorer communities are more susceptible to negative long-term impacts of alcohol. Yet historically, Newham's not been recognised as having a significant issue in this area. And while the data shows a spike around the time of the pandemic, it now appears to be diminishing again. So I'm interested in what made the Directorate so determined to bring this issue to scrutiny. And one of the things I noted in the papers, and I was wondering whether this drove it, is that about 50% of your resourcing is coming from a grant that ends next year. So was it monetary factors that encouraged you to bring it, or are there equity issues that maybe are going slightly under the radar that concerned you, or is it a combination of both?
It's predominantly the latter, so it's the equity issues. So one of the pieces of information that we have got there is, and a lot of members may have participated in this, there is a national programme of health checks for everyone between 40 and 75. And everyone goes through it once every 5 years, unless they've been diagnosed with one of the conditions it's been checked for. And quite a few years ago, we added an alcohol screening test into that check because we were interested, would we be able to pick up on hidden patterns of drinking amongst our population? And we did. So, we have found that there is data in there that on one hand, I think we tend to think of Newham as being quite a teetotal. If we do household surveys, often a large proportion of the population will say they don't drink. However, in the health checks, which albeit is with a very discrete population between 40 and 75, but still a large population, we are picking up levels of drinking that are concerning populations that we might think wouldn't normally drink. And I think it will be interesting when Aidan comes to speak to us about BARTS in terms of that profile of people that are actually coming into the hospital with serious conditions related to their alcohol. So they're turning up later for treatment. So it is very much around the fact that prevention factor about really aware that I think there are underlying levels of drinking that we're not necessarily recognising or doing something about, because we assume that people aren't drinking when in fact they are.
In terms of the test, my understanding with the test you get in your kind of over 40s health checks, where they ask you how many units of alcohol you're drinking per week. I would have thought, as somebody answering what always feels like a very tick box exercise, that people would be understating their drinking.
It doesn't ask you how many units, because most people don't know what a unit is. So it very deliberately doesn't ask that. So there are 3 kind of introductory questions. And if people say no to most of those, they don't go on to the other questions, because that generally means that they don't drink, or they don't drink to levels that are. But it doesn't ask people to name their units, because I think A, they won't know, and B, they'll underreport. So it asks much more questions about, how frequently do you drink? Do you go out? Yeah.
Councillor Gray.
Yeah, it's a fascinating report. Just on this new the paradox, which I found particularly interesting. I mean, what you said to me, unless I misheard, was that there is a greater health harm from drinking in poor, more deprived areas, even if they drink the same. So if somebody was drinking 30 units of alcohol a week in a richer area, are they doing things which offset the drinking compared that Newham residents that don't do, or am I missing something?
First of all, don't be drinking 30 units. Whether you're in a rich or a deprived, I don't know that we know. I don't know that the people that have done that. I just know that there is evidence that has said that there is a correlation. People drink less, and if they're more deprived area and they have other factors, then they will experience the harm earlier and to a higher degree than people from elsewhere. I don't know the mechanics of that are fully understood, but there is very definitely a relationship between the two.
I wanted to ask a question of Aidan Bowen Avery around the new team. I noted that your new team includes a youth worker. Now, in terms of having the team, I think the stat that we quoted when Tom was here around alcohol issues accounting for, I think it was between 12 and 15% of people coming into A&E. But I'm interested in the position of a youth worker, because the anecdotal picture we have is that Generation Z are drinking far less than earlier generations. Is this not true, or does it not apply across the board? What kinds of issues drove you to build your new team?
Hi there. Can everyone hear me? Just checking.
Yes.
Yes.
Yeah. So we know in our emergency department we face we obviously we speak with our ED teams quite frequently through our training opportunities with them, and the anecdotal picture is that they see a high number of emergency departments attendances. As you've noted, NHS England and improvement data estimates 12 to 15% of all emergency department visits have alcohol as a contributing factor, though it may not be the primary pressing issue that patient's presented with. So it can kind of go under the radar. And just as an example of that, I also work with alcohol care teams at Whipps Cross Hospital and the Royal London Hospital within our trust. And at Whipps Cross Hospital, our alcohol specialist nurse, 45% of the patients that they are seeing have no alcohol-related clinical coding. So actually, the coding data that we use to base our kind of decisions and our data on emergency department attendances isn't actually reflecting the kind of impact and the burden alcohol places on our pressures. So that's kind of where that statistic came from. That's the kind of a national estimate on what emergency department pressures are. On the youth worker, so I work with. I've been working with the substance misuse teams within Newham Council for quite some time. We have a regular alcohol forum, which is kind of led from the hospital's perspective, but invites partners in, so we can kind of look at improvements across the board. What we'd noted from the previous substance misuse needs assessment for the from the council was kind of a greater need around preventing early onset of alcohol and drug misuse, and that actually kind of inspired our idea to add a youth resilience worker. Obviously, CGL Newham, RISE have resilience workers, but it's never been something that's been trialled in the hospital, and using that as a point of contact for younger people who may have they might be classed as vulnerable under NICE guidance for several reasons, but they might not actually be currently using substances or drinking harmfully. So trying to get to them at an earlier stage and try and build resilience, look at conflict resolution, and how they can refuse peers when kind of exposed to risky behaviours. So the youth resilience offer is slightly broader than kind of what our alcohol nurses will be doing. Alcohol nurse will be focused purely on alcohol, just given the resources that we have within the service. But the youth worker will kind of more broadly look at risky behaviours and how we can build resilience against those risky behaviours. So not just alcohol.
So, Councillor Ghani, you had a question about demographics.
Yes, thank you, Chair. The report says the overrepresented, the white community are overrepresented. So there are a number of issues relating to this. So how does this break down in terms of country of origin, income, and occupations? And what are the evidence that the unmet needs of non-white communities, particularly Southeast Asian communities, are met? And what level of contract are being made with the voluntary need organization in order to tackle the issue that is identified at all?
So I'm not sure who's best placed to answer the question about demographics. Is that you, Fiona, or would that be someone else on the call?
So I think that in terms of I don't know if that relates to the data that's there from the health checks. Get that from a third-party organisation. They don't break it down any further than that, but we can try and find out if that's useful in terms of breaking that down further. In terms of second part of the question, which I think was around you asking about how we link with the voluntary sector in terms of, I think maybe Lauren Mulligan from Newham Rise might be best placed to speak to that, because Newham Rise are our substance misuse service. They are themselves a voluntary sector organisation, albeit a very large one. But part of what they do is work with community groups in order to get to some of the residents who wouldn't necessarily decide that they wanted to go to a substance misuse service. So I don't know, Chair, if you like.
I think at this stage it might be helpful, but more just in terms of understanding the barriers maybe that some communities are finding with current alcohol services. I mean, later on I want to get on to CGL in terms of what works in terms of treatment. But Lauren, if there's anything you could contribute at this stage about the work you're doing with the community and voluntary sector and about what barriers you're seeing, although it does feel weird as the provider of our service that you would be aware of barriers, because surely if people are not accessing your service, and you're not seeing them to find out that they can't access your service. But if you do have any knowledge about that, I kind of feel like I'm running around in circles here. But it would be helpful to know whether you are hearing that certain aspects of the service at the moment present barriers to certain communities.
Thanks, Chair. I mean, we do know that there are barriers in accessing treatment, even if we aren't speaking to those individuals themselves. I think a lot of what we do is to try and work with smaller organisations in the borough to reach people, as Fiona's mentioned. So you'll see in my papers that we currently have 30 different access points across the borough, and that continues to grow and expand based on intelligence that we receive. So we recognise that whilst we might be the expert in drug and alcohol treatment, we certainly aren't the experts in community as such. So we work with those experts to support us in engaging with the community.
So this is probably a more general question within public health. We've done a lot of work engaging with the voluntary community and faith sector, going out, sharing information in those kind of settings. What kind of reception do we get when we're sharing information about alcohol services? Are other communities receptive to that information, or are they uncomfortable with it being present? Is there a stigma?
It's a shame that we couldn't get someone from Tackleys to come and speak to us, because I think they're very much at the kind of the cutting edge of that. I think that one of the reasons that we don't know so much about what the patterns of drinking are amongst some of our communities is the social taboo around it. I think there are social taboos across lots of different demographic factors. There are taboos for women of whatever around drinking. There are mixed up with taboos where there are cultural or religious prohibitions on drinking, and some people won't want to be talking to their family or their religious groups or the rest of their community about their drinking, so it stays very hidden. So I think it's really complicated because we have to have a kind of multifaceted approach to kind of how we get to people. I think in general, when we speak to community groups, they are receptive. I wouldn't say that we've ever spoken to anybody who kind of goes, well, that doesn't happen here, so go away. But I think they recognise themselves that maybe they're in a position where they're the last people that someone would talk to about their drinking because of all of those kind of social taboos. So it's a tricky one.
I'm just wondering whether Lauren could share a list of local organisations that CGL works with, because I think that would be very helpful to get an idea of who we're sort of talking to at the moment outside the meeting. I'd now like to sort of move us on, just as time's quite tight, onto the enforcement side of this and licensing and policing. So I kind of feel at this stage it would be very good to bring in Councillor Lofthouse, who sits on the licensing committee. Is very keen to ask a question about this to Edward King.
As you pointed out just now, street drinking is actually a two-edged sword. It causes problems to the community in terms of nuisance and also damage to the health of those who are indulging. So I want a two-edged question, really. Partly how do street drinkers feature in the health system? But perhaps first, as this is enforcement, I'd like to ask Edward what licensing is doing, because of course, as we said, ASB, public nuisance, but it's also public safety and the safety of the drinkers. So what sort of success are you having? How are you approaching it?
Yeah, of course. Good evening, Chair. Good evening, members. Licensing is a permissive regime, and we've got 4 objectives we look at when issuing licenses. Public health isn't actually one of them, but we do a lot of work with our premises in the borough to ensure they don't serve street drinkers and they have appropriate controls in place, whether that be training or policies and procedures. We undertake test purchases and we take enforcement action where necessary. I mean, the slides I shared a link to an article in the Institute of Licensing about the successful work we've done trying to reduce street drinking in the borough. And our main method of doing that is engaging with businesses, building relationships, and trying to remove high strength beer, cider, lager, and miniatures from sale, because we find that these are what particularly attracts street drinkers. We work very, very hard in removing the kind of highest strength, highest harm, lowest price alcohol off the shelves, whether that's kind of voluntarily speaking to businesses and working in partnership, or whether it's using intelligence-led policing and data to target enforcement. So it may be that we have a specific premises we know is causing a hotspot for street drinking, and we'll undertake an inspection, a test purchase that's basically the business isn't aware of. And if necessary, we review a license and bring that to committee. That may result in, at one extreme, a license being revoked, or it may result in some conditions. And we have a specific list of conditions to try and deter street drinking. So that's our approach. We use the Newham integrated community enforcement model that meets monthly, and we have weekly GRIP meetings where we look at data and we target our enforcement actions at premises of concern. So we have around 1,200 licensed premises in the borough, and that could be licensed for a variety of things, but one of the licensing requirements is to be licensed if you sell alcohol by retail. So, I mean, we have a really well intelligence-led enforcement regime, and in the pack I shared, I think it was around page 120. I need to get the exact number. There's a link to the article for street drinking and the work we've been doing by the Institute of Licensing, and I think it's a fascinating read. And I'd encourage everyone to read that article to really understand how far we've gone in Newham in tackling this issue. As well as regulating business, obviously street drinking happens in the public realm, and luckily we've got a public space protection order which our colleagues in community safety enforce. And again, its goal is to remove alcohol harms from the borough. By seizing and taking alcohol off people that are going to or likely to cause ASB, or just voluntarily getting them to throw it in the bin. And a mixture of all of these enforcement actions helps reduce the risk of alcohol harm. So hopefully that answers your question. I need to send an apology from Sergeant James Howarth. He couldn't be here this evening. I think the police are incredibly busy at the moment. We have a fantastic working relationship and partnership with the licensing police. And between them and our enforcement officers, we're constantly in venues, whether that be clubs, pubs, or off licenses, and we focusing on enabling safe business. So it's not just about reducing alcohol harm in terms of availability of alcohol, but we also do work around spiking awareness and prevention, safeguarding, and VORG, violence against women and girls. Not only is that in bricks and mortar premises, but we also cover all events in the borough for our safety advisory group. And again, our primary goal is to try and reduce alcohol harm as well as uphold the 4 licensing objectives. But happy to take any questions you may have. Hopefully that's answered your question.
I mean, I definitely corroborate what you were saying about the working you're doing for the police. I was quite surprised with street drinking going down. I realised I hadn't had any casework for a while, but it's one of those things where you assume it's going on and you're just missing it. But at my ward panel, I raised this with the Safer Neighbourhood team, and they were saying, no, it's definitely down. You know, we are targeting hotspots. We're making people pour their alcohol away. My only slight concern for the PSPO, though, is, and I don't know why I care about this because I'm chair of Newham's Health Scrutiny. So, you know, from the point of view of my residents, they will be delighted that they're seeing less of this. But is there a concern that these successes are just shifting the location of an issue or driving it underground?
I think there's always a risk in that, isn't there? And I think the best example for me is during the pandemic. Obviously, we were out there regulating businesses and enforcing the COVID regs. It was hard, and the licensed sector kind of disappeared overnight. And I guess the other side of that is that drinking at home became more prevalent. And I guess this is why licensing is so important, because we want to make sure that we license and regulate safe environments to do licensable activities, whether that's drinking in the pub versus drinking at home. So I guess our role as regulators is to, one, regulate licensed premises and businesses effectively. And that's a double-edged sword, because we have to enable and support businesses. Many of our businesses are SMEs, small, medium enterprises, and local owned businesses. We want to support and engage them and work with them to bring around compliance. But at the same time, we've got to ensure that businesses operate correctly and there's no harm or adverse outcomes on our residents. So I guess we have to have robust enforcement. And, you know, I don't know if that it pushes risk elsewhere. With street drinking specifically, we've been very successful because we've used data from community safety officers, from our CCTV control room, from members and residents' complaints to really kind of pinpoint and then target areas. And in that area, we visited all the licensed premises we're aware of. And I think that that focusing on a specific area has really helped hotspots. It does sometimes push them around the borough. So we did a lot of work trying to remove issues from clusters of ASB in parks, because that was having negative impacts for residents in terms of feeling safe in our green space. And I guess that sometimes we find that if we enforce heavily in one area, I think Maryland was a good example earlier in the year, it could potentially move a problem on. I think our experience is that street drinkers will go from one spot to another. When we clamp down on one premises, there may be another premises that becomes a hotspot. Also, street drinking prevalence is linked to the weather. It's spikes in summer when it's hot and warm, and it disappears when it's cold and it's winter. So again, you know, we find we have UMEs, so unlicensed music events that happen, raves, they pop up more in summer than they do in winter. So I mean, these people presumably will be still doing their activity, but in a different space. So I guess that may well be something. Our role as regulators is to make sure we regulate well, and we keep our public spaces and our businesses safe.
So one of the other aspects that really interested me in papers was unit price increases, which seem to have had a great impact in Scotland, where I saw mobilities were reduced by 13%. I'm guessing we don't have any powers at all to do anything like that in the borough. I'm just wondering whether, again, this is something that maybe we might want to be sort of campaigning for politically. I mean, what's the feeling generally from public health? Would something like that be helpful, do you think, in Newham?
I mean, I think the evidence, as you say, from Scotland is fairly conclusive that it's had an impact on some of the worst health impacts from drinking, and that some of the things that we thought could be adverse impacts actually didn't happen. So, you know, there was lots of stuff around, will people turn to other drugs? Will they use their money to drink and then not be able to kind of afford food? And I think that, you know, some of that just didn't actually happen. So I think there's an evidence base there. They've been incredibly well evaluated. There's at least 2 or 3 universities doing evaluations of them in both Scotland and in Wales. So it's not as if it's an evidence-free zone that we couldn't make representations on.
Okay, that sounds really positive. I'm aware it's 9 o'clock, but I am allowed to run on to 9:30. So with the committee's support, I really think, you know, we've got this final part of the meeting now, just looking at treatment and prevention services, and I'd really like to cover that before I finish. So if the committee could indulge me for, say, another 10 minutes, quarter of an hour, that would be really appreciated. So moving on to treatment and prevention services, my understanding is, as well as Lauren, we've also got Mike Ward from Alcohol Change UK. So Mike, you refer to your organisation's innovative approach to reducing alcohol-related harms. Can you briefly share some of those approaches? And are there any that Newham isn't already doing, but you think should be?
Can you hear me okay?
Yes, loud and clear.
Okay, excellent. Thank you for inviting us. It's good to be here. And I've worked with many of the people on this call before. I mean, as a voluntary organisation, we are able to do some more innovative and more challenging stuff. And we are, for example, challenging the influence of the drinks industry would be something we would want to look at. But I'd want to highlight 2 things which sort of wrap around the work that CGL do. At one level, we've become famous, I suppose, for what's called Dry January, where we're doing kind of national prevention and encouraging people to pursue sobriety, to be sober curious. And Dry January nationally has, you know, hundreds of thousands of people pursuing it. And that is an important initiative, and one that I think should be supported locally, and I'm sure is supported locally. And not just in January, we should be supporting sober initiatives throughout the year. But what I would want to focus on more is the other initiative, which is really at the other end of the scale and links into some of the things that have been talked about in this session already. And that is what's called our Blue Light Project, or the Blue Light Approach, which is working with some of the most complex dependent drinkers. And we have talked in this session about barriers. We've talked about things which stop people getting help. What we need to recognise is that when we're looking at dependent drinkers, probably somewhere, Fiona will know the local statistic better than I, but nationally, 85% of dependent drinkers are not engaged with alcohol treatment services. And those people who are not engaged with alcohol treatment services are many of those who are placing a great burden on the healthcare system. They will be people who are repeatedly turning up in the A&E department. And you will see clients who are turning up 4 or 5 times a day on occasions. And these are people with chronic alcohol problems, probably some level of cognitive damage, and whose services are finding it very difficult to engage. And through our blue light approach, we have shown that we can do something with that client group. And key initiatives that we've piloted at the kind of macro level are assertive outreach and multi-agency management of these clients. And we've worked with CGL to roll out some of those approaches in Newham. And nationally, those kind of approaches are getting very good evaluation. And for example, our work was included in the National Clinical Guidelines on Alcohol Treatment. And we won a Guardian Public Service Award for this work. We can make a difference with these very complex clients. And an example of the kind of more micro stuff that we do is hidden away in the possible answer to the question that was asked about why do we have the alcohol harm paradox? Why do rich people suffer less harm from their drinking than poorer people? And Fiona's right that we don't know for certain what it is, but 2 reasons that have been put forward and which are very likely is that wealthy people eat better and are unlikely to smoke. And those 2 things make a huge difference to chronic dependent drinkers. Many of the dependent drinkers we're seeing are turning up at hospital with alcohol-related harms, but also with smoking-related harms, and often with very, very poor nutrition. We've seen clients who have the body mass index of someone with extreme anorexia. And we've shown how assertive outreach using harm reduction techniques can make a difference to those people, can reduce ambulance call-outs in an area such as the northeast of England, can reduce the burden on police in, for example, Buckinghamshire. We can make a difference to these clients, and the Blue Light Project and the work we did with Newham on the Blue Light Project has shown that we can make a difference with that. And my basic message is we need to continue to push those approaches as part of the local treatment system.
Okay, if I can bring Lauren in, can you just sort of tell us a bit about what you're seeing in terms of any changes in the people coming through your door and what actually sort of works with the people that you're working with specifically?
Yeah, I mean, I think in terms of changes, we are seeing a greater level of complexity and people coming into treatment with very poor physical health. In terms of what works, Mike's touched upon some of the initiatives that we have currently in the service around assertive outreach, meeting people where they're at, and creating a tailored treatment plan that focuses on their own individual goals. So you'll see in the papers that I've listed some of the interventions that we provide, which look at clinical treatment for alcohol misuse, but also the psychosocial aspect. So looking at what else is going on for an individual who comes to us, because often alcohol use is a symptom of something else that's going on rather than, just what they're doing. So it's working with partners. I would say we work really closely with both the statutory and non-statutory partners to provide wraparound support for our service users, and working with them where they're at is what works.
Have we got Sarah Curry on the call as well in terms of, yes, we have. When we procure our alcohol services, how much co-production work do we do to make sure that those services are going to work for Newham's communities?
Thank you. That's a really important question. And I think we are aiming to increase the co-production work that we've done. We re-procured our services last year in 2024, awarded a new contract. And as part of that, I think for the first time in a while, we did work with the co-production team within the council to bring together a range of stakeholders, including our residents, both those who do use substances with our alcohol or drugs, or families and others that are impacted by someone else's substance use, into focus groups. And we discussed various topics, and including the barriers to accessing treatment and how best we can support our residents around their substance use or somebody else's substance use. We also have within Newham Rise a number of people with living and lived experience who are part of the service and do come back to the service to act as champions, as peer supporters, contribute to service user meetings and surveys. So we constantly have this this feedback loop that we are gathering views. And of course, the work that Lauren and colleagues have touched on in working with the communities and our community partners to better understand their needs and barriers and how we can make our services more accessible and meet them where they are and increase our community reach. For example, delivering services outside of this main service hubs like family hubs, the youth zones, etc.
I mean, that was one of the things I wanted to sort of check, that we are speaking to people who are outside our existing services, because otherwise it kind of feels like a circular argument in that the people for whom the CGL approach works are obviously going to say that that's what they want. And it kind of feels to me that we should be spending time speaking to people outside of that who we could possibly access through NHS colleagues in terms of understanding maybe why those services may not be working, and ensure that the kind of service offer is broadened. I mean, my final, yeah, go on.
Sorry, just to add, I completely agree, and I understand that is a challenge. And as Lauren mentioned earlier, we may be the experts at offering the services and the treatment, but may not be the community of it. And Lauren and I are working with our comms team to better understand the channels that we can reach the community at, and reach to them where they are. So instead of expecting them to find our resources and our information, we're going to try different channels to promote the services and raise awareness.
And in terms of those channels, I'm hoping that you're speaking to the communities to see which channels work for them, rather than speaking to a comms team who no doubt can sort of shape a really good message, but maybe not for our particular sort of communities. I mean, I think the one thing I haven't quite got an idea of is in terms of the work we do with people to sort of steer them away from alcohol, what actually works in terms of treatment is, I mean, you hear things about art therapy and cooking and things like that. What is our kind of physical offer in terms of steering people away, or is it some form of therapy? What works here?
If you don't mind, I might bring Lauren to speak a bit more about this.
Yeah,
but I will mention working with our subcontracted service, or CGL subcontracted service, Build on Believe, who deliver some support outside of our core hours in the treatment offer, and do support people who are not engaged with CGL Newham Rise. And Lauren, you would like to mention about Driving for Change bus as well, and the support that they offer.
Yeah, just an idea of what you're actually doing with people that sort of actually works to get them to sort of cut down or quit alcohol.
Yeah, so we have a number of pathways in the service. Some are clinical pathways, some people require medical intervention, and our support to reduce and stop drinking, then we have a lot of psychosocial pathways. So for example, we have groups happening all over the borough all day, every day, where people learn about their alcohol use and relapse prevention. We have access to counselling in service, and we have good referral links with mental health services as an example. And then you touched upon some of the extra groups we do, which is all run by a recovery support team. They're a team made up of individuals with lived experience who have now come to work with us, and their aim is to support reintegration into the community. So they run groups that are focused on individuals' well-being and how they can get back into things like work, and how they can continue with their recovery journey once they are finished in structured treatment with us.
And I guess my final question from me, carrot or stick, works better? Nice simple question.
Can I say that depends on the person?
Very fair answer.
And then reasons for drinking in the first place.
Yeah, I mean, are there any other questions from the committee at this stage? Councillor Corbyn.
It's just a bit around, it's sort of been touched on, but the psychosocial thing, that the reasons why people drink in the first place, because if you change the reasons, if you can intervene even earlier potentially, and there's so much to unpack there really, but you could intervene before they start, because addictive behaviours often are born out of stresses. So but how are we going to remove all that stress from people's lives? Not that easy, because a lot of the time it's the people drink because effectively they're avoiding pain. It's not only drink, it's not only alcohol, but all, you know, drugs, other addictive behaviour, gambling, all these things that cause huge problems. It's because they do it for a reason, because it provides something that they haven't already got in their life.
I mean, that was going to be one of my questions, actually, in terms of what drives drinking in Newham. Are you finding that there are specific reasons? And you want to answer, and then I can see two other people who want to come in. Did you want to come in on this specific point?
I do, but I've asked a few questions already, so anybody hasn't.
Councillor.
My question would be about things like, patches, you get sort of patches for drugs.
That's slightly different, but if we go into the reasons why people in Newham are drinking, and back to Councillor Mohammed's question.
I mean, I'll probably defer to Lauren because she's got much more clinical relationship with individuals that are actually going through treatment. But I think again, it's a bit like my answer to the carrot and stick. You know, some of the stuff that I've got a long history of working in substance misuse. I started working with substance misusers in 1990, and the reasons for people using drugs are many and various: boredom, stress, adverse childhood experiences, the fact that they come from a family that drinks a lot. The fact that they, you're absolutely right, that they might be experiencing mental health symptoms and they start to drink because that alleviates some mental health symptoms, or vice versa. It's really many and varied, and often they won't know themselves until they go through some of that psychosocial support, because it's just something that's crept up on them. That's why we're seeing some of the stuff from COVID. That whole rate of drinking went up because people were at home and they were drinking what they bought in the supermarket or got delivered to home, and there were no limits on that, and they had no other social life, so they were drinking more. But some of them aren't able to stop.
Councillor Gray, did you want this precise point, or is it?
No, it's a provocative point as well. So,
Councillor Lofthouse, is this related to, or is this new?
It's really related to that. Edward would corroborate this, but also gambling is more prevalent in the deprived communities. So there's more alcohol, more gambling. It's part of the answer to the question. That's what I would say.
And Councillor Mohammed, and your comment on patches.
No, I'm just saying, in terms of, when residents do come for support, and obviously there's serious case of alcohol misuse, do they use such thing as patches to? Because I know I've met residents that from drug misuse have patches, and they tend to go down the patch route. But do we have any sort of sort of support there or patches that can.
So again, I'll probably defer to nicotine patches to Lauren. I think what you offer as a medical intervention varies by the drug. And I think that we probably need to also recognise that actually withdrawing from alcohol is very dangerous, much more dangerous than a whole host of other things. So, you know, it does have to be done in a kind of clinically managed way if someone's dependent. So I don't know, Lauren, do you want to come in?
I can do. So we provide treatment in line with NICE guidelines. There isn't patches available for alcohol misuse that I'm aware of, but we do provide medication either to manage the withdrawal symptoms from alcohol dependency or for relapse prevention purposes. So we've got lots of people that continue to access the service and with our recovery support offer who are in receipt of medication that manages cravings. And we then look to transfer that onto GPs for longer term prescribing if somebody ends up leaving us successfully.
Okay, I'm very aware that time-wise, we've had our extra quarter of an hour. Are there any points that colleagues still on the call feel that have been missed, that they would like the committee to sort of know before I wrap up? Councillor Gray, I was asking partners, but if you've got another question.
Just I do actually, I'm really interested in this, is alcohol does, there is an argument that we have a very restrictive culture towards drinking in this country, and also about other forms of drugs, which people would argue are less harmful. And I'm talking about a debate about decriminalising cannabis in particular. I'm not a cannabis smoker, and I have not since I was a student decades ago. However, it does see, and I appreciate that there are harmful effects on smoking certain types of cannabis, but there is an argument that certainly the violence and the sort of destruction to people's lives from alcohol is particularly dangerous. And if we had a more sort of liberal, inverted commas, approach to drugs, it would cause less harm, perhaps, and it certainly may benefit people. I don't know if there's international research in this in other countries now, but I do. Walking out tonight, I've never been attacked in the street by somebody high on cannabis. But I've had lots of problems with people who are drunk out of their minds.
I mean, that's
that's a whole other meeting.
Another meeting. Are there any other points on the issues we've been discussing tonight? I saw Councillor Aguda, do you have
Yes, I just wanted to find out about the public health outreach. Are you making any difference in the community at all?
Can I ask Lauren, who's in charge of that, to answer that?
Yeah.
Councillor Laguda for you.
In short, yes. So our outreach team, you'll find them at the hospital, at the mental health wards, in hostels, all over the borough, and it has made a huge difference in terms of access. So historically, we would expect people to come to us to access treatment, and it's very much the opposite now in that we will go to them. So yes, in short. You can see in the papers that we've seen a massive increase in the number of people accessing the service, particularly around alcohol use. So in the last few years, we've seen a 40% increase in alcohol users in treatment. And I think a lot of that is to do with access and availability of the service.
Councillor Mohammed is
around homeless
the
alcohol abuse, because obviously when we do our street count, a lot of homeless people are against alcoholics. They're out on the street. In terms of what support is there out there for them, and do we sort of, it's about tenancy sustainment, and do we give that support there and try to clean them, get them off alcohol, and then eventually jobs? What sort of support are we doing at the moment around that?
So there is a specific rough sleeping team that CGL has, different part from Lauren, but there is a specific rough sleeping team from CGL that do go out on the street counts, and they go out and they go out on the outreach, and that's specifically around supporting people to get them to a point where they're able to use services. But I think, it's
That's annual message by any chance, because someone's
hoping something else.
Yeah, he's got his hand up at the moment, so I don't know whether is that related to the points we're just making, or a previous point.
Yeah, well, it's relating to the points we're making and the previous points, if that's okay. So one thing I want to mention, I can't remember who asked, but there was a question around prevention. I wanted to mention the work that Lauren's team does and that we commission around the whole family approach to make sure that kind of recidivism, so children who are in houses where there's a high level of drinking, there's less impact, they're less likely to go into drinking. But in terms of the outreach and the street work, I wanted to make a special comment on the Newham GRIP, where we work with the police, our neighbourhood outreach teams, our street communities team, the environment teams, our CCDV teams, to target outreach and to work with people in terms of making sure that we work together to get people into treatment, to reduce antisocial behaviour and improve the community for all of our residents.
Well, thank you very much for that. So if I can sum up, I think some of the key observations we've made are, firstly, we'd like a list of organisations within our community that CGL are working for to sort of understand that things work better. I really think we need to sort of look at this classification of one, and what communities sort of apply that, and better refine our sort of data around ethnicity in general. And then I think it's one that we definitely need to continue to monitor going forward. But I think it's been a very rich conversation tonight, and I'd like to thank everybody who took the trouble to attend, and in particular Fiona Hackland for pulling this rich panel together. So I'd like to move that the reports we received are noted, and the committee's observations and recommendations from the discussion to be recorded and taken forward as part of our scrutiny of alcohol harm and inequalities. Is that agreed?
Agreed.
So we now come to item 9, which is the date of our next meeting, which will be Tuesday, the 11th of November at 7 p.m. here at East Ham Town Hall. The meeting's time is now 9:25. So at that point, I thank everyone who's attended and formally close the meeting.